Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Yeah, great. Thanks, Brian, and hope everyone had a good 4th of July weekend. So Brian asked me to go over both the CDC and the U.S. Preventive Services Task Force recommendations. And these came out in February and right in the heart of the COVID epidemic in April. So I'm sure everyone was occupied with other things, but these are pretty significant documents, and I wanted to go through those. So these are my disclosures. Pretty simple objective that we just want to be able to list which patients should be screened for Hep C in the United States based on these two documents. So I wanted to start out by just giving a little bit of historical context of how the screening guidelines have evolved through the years. And fortunately, what you'll see is that they're a little bit simpler with each kind of iteration. But winding back to 1998, when the CDC first released their guidelines, it was really risk-based with a target of patients who had used injection drugs. And then there was a list of other populations there. So relevant to our discussion today, HIV positive patients have always been recommended to get a Hep C test. But probably the most common way that I see Hep C being diagnosed in the primary care setting was just an unexplained elevation in the AST and ALT. We know that hemodialysis was a population that had a lot of hepatitis C. Hemophiliacs, sex partners of HCV positive, organ transplant recipients before we were screening in 1992, healthcare workers after needle stick, and then children born to HCV infected mothers. And there was a lot of analysis of the strategy, and I just think it's pretty long. It's pretty confusing, and primary care doctors are very busy. So unfortunately, it just wasn't really being used that often. So then in 2012, the CDC said, well, let's try to go after the population that has the highest prevalence of hepatitis C. And those are baby boomers. So those born between 1945 and 65. At that time, we thought about 75% of all patients with Hep C were born in those years. And of course, they did include the risk factors above. But really, that allowed things to get a little bit more simplified in terms of rolling this out in many people's practice. So jumping to February, the U.S. Preventive Services Task Force recommended that all adults aged between 18 and 79 get at least one test for hepatitis C. And this is a grade B recommendation. The reason why I highlight that is for a couple of reasons. First of all, is that if anything is grade B, it tends to be almost uniformly paid for by insurance companies. So that's often a big barrier for patients if their insurance doesn't cover it. So that's good. The other thing is that when things are grade B, they tend to get rolled into a lot of the healthcare and maintenance activities. And a lot of these things just get automatically kind of loaded into our electronic medical records. So hopefully making that a little bit easier. This article was led by Doug Owens. The only reason I highlight that is that he was my first boss and a great guy. And I know he did a good job on that. So some of the things that the U.S. Preventive Services Task Force was looking at was just the changing epidemiology. Recall that I had mentioned that this tended to be an infection that affected baby boomers. But in the last 10 to 15 years, as the opioid epidemic has really taken off, we've seen that it's skewing younger. So instead of there's being a big peak, it's almost like a two-humped camel. We're seeing this new peak in 20 to 30-year-olds. It also is no longer a predominantly male infection. It's pretty even, male and female, and unfortunately is attacking Latinos and Native Americans at a higher frequency. So still a recognition that there are increased risk groups that are kind of falling out of that range. So those who are using drugs before the age 18, or maybe those who are over the age of 79 and had used injection drugs. They also recommend that all pregnant adults be screened, including those under the age of 18, and any antibody test that comes back positive should get a PCR for confirmation. In terms of the frequency, most adults only need this once, but if there is ongoing injection drug use, they recommend more frequently without really getting into specifics like how often. So a little bit of nebulousness around that. So they do have some good guidelines on what are the best practices for how you roll this out, the first thing is to just communicate with patients that this is voluntary but recommended, and that the patients should be kind of in the loop that they're doing this test. And also some kind of standard counseling, just like we do for HIV, like how can you get it? Hep C, how is it spread? What does a positive antibody test mean versus a positive RNA test? Plus a kind of recognition of what the next steps would be if a patient comes back as being infected, and in terms of the benefits and harms of treatment. And then just like any other tests we're doing, we need to allow for the time to answer any questions that our patients might have, and that they can decline the screening. So some of the data that they go over to support these conclusions is now the very well documented benefit of the directly acting antivirals. So all-cause mortality has gone down 60% in those patients who have been treated. And that's for all kind of classes of fibrosis. Obviously, the biggest benefits in more advanced fibrosis. And just to kind of give you a little bit of a perspective on that number, statins for secondary prevention have about a 20 to 25% reduction in all-cause mortality. So this is a pretty hefty impact and survivability. Liver-related mortality goes down 89%, cirrhosis 64%, and hepatocellular carcinoma 71%. So across the board, really broad benefits to patients who get an SVR. So they found in their modeling that if this was implemented widespread throughout the United States, it would find an additional 250,000 HCV-infected individuals, leading to 280,000 receiving curative therapy. I think that's because some people would get a secondary course if they failed, and would avoid over 4,000 cases of hepatocellular carcinoma. So this is just a graph showing the cost effectiveness of universal screening. In the black here is the current baby boomer and risk-based strategy. And then they looked at cutoffs of 40 years old, 30 years old, and 18. And you see a jump in all of them, but kind of a minor increase, with the best strategy being over the age of 18. So that's the U.S. Preventive Services Task Force. The CDC did a separate analysis and kind of came to similar conclusions. So they recommend HCV screening at least once in a lifetime for all adults over the age 18. And the one exception is if there's a very low prevalence, so less than 0.1%. That is very rare in the United States, but they do call that out if we ever get to that kind of benchmark. They also spend quite a bit of their time exploring the benefit of screening hepatitis C for all pregnant women, and they recommend it for each pregnancy. So not just the first one, but each pregnancy, and again, use this 0.1% as their kind of floor for screening. So their basis for this is just the graph showing how hepatitis C was going down in the early 2000s, but then really started taking off right around 2010, and is basically back to where we were 20 years ago. I think there's a little stutter here in 2015, but my understanding is then going back up. So we think there's around 45,000 new cases of HCV that occurred just in the year of 2017. That's quite a bit. So just looking at states in terms of their HCV positivity, and there are two groups that are looking at it. One is the overall, so that's kind of the lighter shade of purple. And then in pregnant women is in the darker shade. So the top states here are West Virginia, Kentucky, Vermont, Montana, and Tennessee. And just kind of calling out other states in our WWAMI region, Alaska is about number 12. Oregon is around, I think, 17. Washington's kind of in the middle of the pack. And then your bottom states are Hawaii, California, Nebraska. So the only state that has that is less than that 0.1% threshold is in Hawaii, and that's for pregnant women. So I guess they could potentially not implement this and still be within the guidelines. So I just wanted to put in a table form the various specialty societies who have weighed in on HCV testing. We talked about the USPSTF and CDC, which are in the first two columns there. Also wanted to call it the joint guidelines between the Infectious Disease Society of America and the American Association for the Study of Liver Disease. That's the hepatology group. And then the OBGYN group, so the American College of Obstetrics and Gynecology and the Society for Maternal Fetal Medicine. So let's just kind of go through this. So PWID, all groups have said this should be done. And I think the most helpful is in the IDSA ASLD, they should say it should be done annually. So that helps you out in terms of the frequency. For adults, they said all groups are saying it should be done at least once, with the CDC kind of giving this caveat about 0.1%. So when we get down to pregnant women, this is where you start seeing a little bit of discrepancies with, again, some strong concordance between CDC, the USPSTF, but the IDSA doesn't really get into whether you need to have testing on subsequent pregnancies. And then ACOG has not really endorsed this widespread screening. So they're only saying if there's risk factors present. And when I've reached out and talked to those folks, they list a couple of concerns. One is just unintended consequences that happen when you're testing a woman. So those include stigmatizing behavior, loss of insurance. Also, in some states, if a woman tests positive for Hep C, that kind of infers that maybe she was an injection drug user, and then Child Protective Services can get involved, and they might actually lose their child. So that's a pretty major concern there. There has not been a whole lot of study of antiviral treatment in pregnancy, just one large study from Pittsburgh, or actually not large at all. It was 10 patients using Harvoni, and those women all did well, all got cured, and the babies did well, but only 10 patients. So that's not a huge database there. Also, there's some recommendations that if a woman's Hep C positive, that they don't want to do as invasive monitoring. So like scalp electrodes and amniocentesis and things like that. Sometimes that impairs what the OBGYN can do. And then they just raise concerns about how do we roll this out? How do we make sure that women are getting tested during their prenatal visits, and then also the babies, when do they get tested? Usually it's at 1 year, but sometimes those kids can get lost in the follow-up. And we have not done a real good job in making sure those babies are getting tested. And then lastly, some of the issues with testing pregnant women is that many women are on Medicaid, and it's only valid for the time of their pregnancy. So they may not get follow-up care for their hepatitis C, and this might be deemed as a pre-existing condition. So there's some other logistics of operationalizing screening, including reflex testing for PCR. That's something we do here in Washington State, but a lot of labs don't do it. So it's another stick to get that PCR test. There are a variety of health systems that have used EMR prompts, or just kind of making it automatic, and kind of shows up on your screen. It's listed as health maintenance. That's what we do. I know Providence in Swedish does the same thing, and that's been really useful to kind of remind PCPs to do this, and then just make sure that the patients are getting the results and they know where to go if they're testing positive. So that's all I had for today. I'm happy to answer any questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.